All right, this should be recording. Okay, good morning, everybody. Thank you so much for being here. And I just wanted to say, we understand that there are so many people in really challenging situations right now. And so we really appreciate you being here, and we hope to support you in any way we can. Thank you to our speakers, Dr. Hughes and Dr. Fuller. Thank you to our discussants, Dr. Jairam and Dr. Maddox. And then, of course, thank you to our host, aptly named Dr. Host, who will be introducing all the speakers now. Also, if you could put your questions during the lectures in the chat, I'm going to be writing them all down and categorizing them so we can go through them expediently at the end.
Thanks, Dr. Davis, and for your time. And we are now start our our lecture series on our trauma case series. And it is our great honor for me to have our eminent trauma surgeon and emergency medicine physician from US for joining us virtually today and for your educational support. First of all, I would like to thank Dr. Maddox and Dr. Maddox and Dr. Andrew Garman for their continuous support for this trauma education program happen. So we have some formal introductory aspects I can for this world-renowned speaker. It is a great honor for her to have has a Dr. Maddox today, and I think I have introduced him very well, and all of you have known very well about his many years of trauma experience. And now we have another speaker, Dr. Melly Hush, who received her MD from Harvard University and completed the residential training there and went to the MPH in disaster management from Tulane University and focused on analysis of trauma and injury pattern occur in the disaster event, and have a several publication on this collaborative multinational. Well, Ada joined the Stony Brook as a fellow in master in general surgery, and commission of her fellowship, she joined a full faculty and of the staff there. Together with Dr. Hughes, we have Dr. Matthew Fuller, MD, Assistant Professor Clinical in Emergency Medicine and Adjunct Professor of Orthopedics from University of Utah School of Medicine, also served as the speaker. Dr. Fuller graduated from University of Iowa College of Medicine, and he began his clinical training in University of Utah Hospital and Clinic, and completed his residency and fellowship in emergency. And another discussion is the Dr. Sudha German, MD, who is also a professor of medicine in the Division of General Surgery at the University of Utah, and she completed her training at the UCFS for general surgery residency and obtained master's degree in public health at the London School of Hygiene and Tropical Medicine. And she worked on several projects on trauma epidemiology, and she finished his critical and acute care surgery fellowship at the Brigham and Women's Hospital at the Harvard Medical School, where she was invited at the Harvard Medical School fellowship. She also have authored numerous publications on injury, and also a author of and peer reviewer of the Cochrane Systematic Review Injury Group and collaborator. And now we are also taking care of our Myanmar people, where our fighter jet fly over the battlefield and volley of resistance from the air to our innocent people. This trauma educational program will help to take care of our patient care for Myanmar doctors, trainees, and residents. Without further ado, I'd like to now hand over to Dr. Davis from Bangkok Hospital, who is also one of the outstanding trauma surgeons in the US, who has served as a moderator of today's discussion. Dr. Davis, thanks for coming back to us again, and over to you.
Thank you so much, Dr. Host, and thank you to all of the trainees and students who are present. First, we're going to start off with Dr. Hughes talking about triage in the field.
Nice to meet you guys. thanks for having us, Dr. Host, and I really appreciate the opportunity to talk to you guys. This is just quick background. I'm at Stony Brook at this point, even though I've worked overseas and in low resource areas most of my life. I'm vice chair of surgery at one of the outer hospitals, and then I'm also a professor at the university. And my practice is typically a mix of trauma, general surgery, and endoscopy. So a little bit of background. We all know about trauma statistics. This is the only slide that's sort of like this. More than 5 million people are killed due to injury from traffic accidents, falls, drowning, burns, poisoning, violence, acts of war. And that ends up being more than those that are killed from HIV, AIDS, malaria, and tuberculosis combined, which is a staggering number, and many more injured. These are just the fatalities. This is an old sort of concept that we're changing it to from trimodal to a bimodal more concept, and that's because of triage and rapid restoration of patients from the moment of trauma. So they talk about a golden hour, which happens immediately after injury. And this is where 80% of trauma deaths will occur in that first hour. And if you have rapid trauma response, rapid triage, that has the greatest impact to save patients. And it was these principles that actually help develop modern trauma and guide how that has been developed worldwide. So I want to talk about two different concepts. One is surge capacity, which is the ability of a system, healthcare system or locality to respond to an increased number of patients. But separately, there's an important thing about surge capability. So it's not just the capacity, but also the ability to address a lot of patients with unusual or specialized medical needs, people that may have diabetes, people that may be wheelchair bound or have other complex medical conditions. And that's part of what you're looking at as you're working on the triage process. Do you have the capability to address not just a lot of patients, but complex patients? And then the most important thing for me in terms of looking at triage is that when you're in a disaster and things are happening, it seems sort of callous, but the effective management of resources will influence the overall outcome of the response. If there's a low number of victims and a low complexity of injuries, and resources are abundant, then that has very little impact on overall outcomes for a particular event. But now the opposite is true, and the number of victims are high, they have a lot of complex injuries, and resources are low or limited, then that is a time when resource allocation and triage can help determine outcomes for patients. And this is what the talk is about. And you don't want to talk about rationing, but it is actually a form of rationing. When you use triage. During large surges or sudden patient surges, this is a way that we try to address resource shortfalls. And so what is the word triage? I like to just give it down. It's a French word coming from trier, and I know I'm not pronouncing it right because I'm terrible, but it means to separate out or to sort. And that's exactly what triage is. We want to sort patients and prioritize care based on the severity of the patients and how much the help is going to be of use to them. We also secondarily want to ration resources to optimize availability and direct them to the most needed. And a lot of us saw this, have seen this, and are still seeing this with COVID. Resources have rapidly outstripped our ability to manage them. So we say in reality that triage is seldom used to ration care, but there's hospitals in Texas. Yes, Dr. Davis, Dr. Maddox, where they've reported, the ICUs are full, and then they have to make decisions about sending patients home. In terms of the overall structure for disaster responses, from a medical standpoint, this is sort of the workflow guidelines. We're only going to be talking about this first box here, which is just talking about triage, which is conducted basically during search and rescue events, or when the ambulance or EMT team or whoever's going lands on the scene. So the rest of this transport, treatment, God forbid the morgue, and supply chain is a separate talk. So again, we're going to be talking about primary triage, which is in the field. So that's when you arrive on the scene, there's been a mass casualty, or even just one or two individuals. Getting them to the proper space and getting them to the proper place is important. And I want to give you guys some guidelines on how you're going to make those decisions. Secondary triage occurs in the emergency room. And then from there, within the hospital, you know, patients going to radiology, the OR, ICU, we all know this from ATLS, the trauma training guidelines. And so, whew, it's sort of a hard, this is the hard look of it. So this is being done by people that have some aspect of medical knowledge, but in some cases, it's not. Sometimes it's laymen or just people that are available and actually still walking, able to do this sort of triage process. This is an example of a triage tag that you can find on Amazon. And they also have versions that don't have any words in them, so they can be used universally. And they actually classify patients by color. That's what we want to do. So those who will survive, whether they receive care or not, those come into the need care, but it's not urgent, yellow in some cases. Green is that they don't need care, or you know, they can go to a local field tent or this kind of aspect to fix what they're doing. And then the most important part of this is that there are those that will benefit significantly from interventions will be tagged red because they need immediate intervention to save their life. And then there is also the decision to be made that there are those that are very likely to die, and we'll talk a little bit about this, despite maximal medical effort. And those end up with a blue or black designation for triage protocols. So you actually just take this tag, attach it to the person's clothes, attach it to them somehow so that the teams that are coming behind to start transport or start directing patients can work on that process for triage. And so we're talking it again, it is to sort. So you do want to identify the dead and those that are too severely injured to be saved in the case that there's an outstripping of resources. You want to send any of those with relatively minor injuries and wounds to a holding area to await treatment anywhere else. And then, like I said, the long-term goal for this is to get people to surgery or to life-saving intervention. And so you want to identify those people, and that's what makes a difference in this process. Again, this is just a flow chart showing from our standpoint. So the previous chart, this is coming in further at the search and rescue stage. We're going to push patients to immediate care, delayed care, minor care, and then, you know, in some instances to the morgue. This is just saying the same thing, but I just want to clarify a little bit better. An immediate person has a life-threatening injury, and we'll talk a little more about that. That demands, it needs immediate attention, either there on the field or with rapid transport to a local area where they can be saved. Delayed injuries will not jeopardize the person's health. I'm not saying the person's not hurt. They may have, and that's, I think, what Dr. Fuller will be talking about is some of the types of injuries and how to recognize that process. They may need professional care, casting, etc. They need it, but the treatment for that can be delayed. And then the last are the walking wounded. They tend to be ambulatory. And then in terms of the dead patients, it's not just the patients that are clearly have expired, but unfortunately, it's also those patients that after 2 attempts to open the airway, as we talked about in the previous talk, they don't breathe spontaneously. And in the case that there are more victims than rescuers, CPR should not be performed in the field. That's the long and short of it. In all aspects of triage, the process to respond is critical. That time that you have is how you're going to save a life. You have to be very, very certain that you don't spend very much time with any single person. You need to delegate in this process. You need to push to other people, and you need to tag and move. And then also remember that you want to do the greatest good for the greatest number of victims. That is the overall process in large mass casualty events or even smaller events where resources are limited. So when we talk about these immediate patients, the red tags, in emergency medicine, they talk about these killers, and it's the same for trauma. Things that are, you know, causing airway obstruction. You want to get that airway open. Bleeding, you want to stop bleeding. And I think that's a whole separate talk, and we've talked about airway already. And then shock, additionally, in ICU management treatment is another separate talk, but I'm going to touch on all 3 of these as it relates to triage. And these are the 3 things that without treatment, they will lead to death. And so in triage, it is exactly the same process. We want to look for these things to help save the patients that are recoverable. So this is a quick little terrible chart, but it has all of the steps in one little succinct thing. In some cases, people will print this on cards for people that are responding to triage. So you do want to check the airway, the things that we talked about, check for breathing. If it's above 30 breaths per minute, excuse me, that can indicate shock. You want to maintain the airway and you want to tag them. If they're below 30 breaths per minute, likely the patient's doing okay. And if they're not breathing, then they're dead. That's how it goes. And then the next step is the bleeding. So the first intervention under all circumstances is going to be the airway. And I'm not sure how much we went into detail about this. So the airway is not just checking for obstructions, but also for patients that are unconscious, making sure that they're able to breathe. So I know that that's something that was already discussed. So I won't beat that horse again. In terms of procedures for controlling bleeding, we're not talking about surgical intervention for a lacerated artery. In the triage setting, we're talking about just stop the bleeding on the spot. A lot of times, direct pressure over a wound, you can put a clean dressing a lot of times, and then just hold firm pressure. A lot of times, 10 or 15 minutes of pressure on a person, if you can spare the time, will stop most non-significant arterial bleeding. In the cases that the bleeding is stopped and it's looking like you've got control of it, then you do want to tie something, not a tourniquet now. You want to tie something around with some pressure and tie it with a bow. And then you also want to elevate that wound above the level of the heart to stop the bleeding in that region. There's some pressure points that you can look for certain limbs. And I'm going to show you a diagram on the next page, but it's the brachial point for bleeding in the arm. There's a femoral point for bleeding in the leg, and there's the popliteal point for bleeding in the lower leg. And so this is when you're looking at the brachial artery, you want to stop bleeding just to that point. You want to hold just above the elbow. For the femoral pressure point, it's in the upper thigh where the femoral vessels course over the bone and they're easy to access. And then in the popliteal area, it's behind the knee. I didn't even want to put this slide here to talk about the tourniquet, but I think in some cases it can be limb saving and life saving, so I did put it in. And there are options for medical tourniquets and emergency management has tourniquets and these types of things, but tourniquets can really cause some problems. So we do advise not using a tourniquet unless it's actually the patient is exsanguinated. And so these are just guidelines to how to put the tourniquet on, and these will be available to the top. But the most important guidelines are that you do want to mark the patient about where the tourniquet went. It should be above the wound, closer to the heart. So, and then you do not loosen the tourniquet once it's been put on. And then that should only be removed by someone that's going to actually definitively manage the bleeding. And then shock is a third killer. Is a condition that occurs when there's not enough blood flow to the parts of the body. So when there's no blood flow, there's no oxygen. And so the tissues and organs start to have compromise. So blood vessels begin to close off, organs are damaged, and if they're left untreated, they will shut down. This is when we talk about multi-system organ dysfunction or failure. This is the process. No matter what the cause of shock is, it can be septic from an infection, it can be trauma related from bleeding to death, it can be cardiogenic from a heart attack. No matter what it is, we have to restore or find a way to restore that blood flow. But in the field, what we're trying to do is identify these patients and get them to immediate treatment. And so for triage members, the main things that you're going to be looking for are rapid shallow breathing that's greater than that 30 breaths per minute. When you check cap refill, you can just push on a patient's finger. The capillary refill is, if it's greater than 2 seconds, that's a sign that they have bled a significant amount, or that they're not perfusing the periphery of their body or the edges of their hands and feet. And so that is another sign of shock. And then also if they're confused or failing to respond to simple commands like squeeze my hand or are you okay, they're not responding. This patient needs to be red tagged in addition to the patients with the airway and bleeding issues. In terms of shock position, this is this is what we can do on the local scene to just get people there until transport can move them. You want the patient on their back. The feet need to be elevated between 6 and 10 inches above the level of the heart. And this will help bring blood to all of the vital organs and help the patient survive if it's possible for them to survive. Another thing is that patients tend to be cold. You want to make sure that you wrap them up. And if the ground is wet or there's any issues, we want to try to put things under the patients so that they don't, get hypothermia. So in some cases, it can be productive. And so the procedures for controlling the shock portion of this is to maintain the airway. That's number one, no matter what. Control obvious exsanguinating type bleeding. And then we want to maintain body temperature. And for the transport folks, I know that we're not into that discussion necessarily today. You do want to avoid really rough and excessive handling for the patients. It can sort of like trigger and traumatize them. And then you do not want to give any patient that you suspect to be in shock anything to eat or drink like you would some of the other walking patients, because they're likely to need surgery or intervention, or they may vomit and then choke on the food. So it's not too, I'm not going to go. So this is just an overall decision flow chart for the same thing that we've been talking about. I'm not going to go back over it. And then looking at field trauma, it's super dynamic. This is a little bit different. This is when you're in a field. This is a hurricane in Guam. This is a fire in Morocco. And in this case, the emergency medical care for these injured or critical patients is still going to be important. And when we're talking about the field and the things that will ensure success over time is that the triage in different places should be practiced. There should be disaster drills. There should be practice from hospital setting, field setting, even ICU setting, to make sure that people respond appropriately. In terms of disaster, you do want to make sure that you're going to be safe. In the case of the hurricane, there's not much help it's going to be for you to go outside and then get blown down the street too. So you do want to look at a situation, make sure that it's safe. Are you going to approach a situation? And if you are, you do want to make a plan that allows for the team members and the rescuers and the triage members to be safe. This is just some more detail of the actual field triage. The first thing you should do in all these settings is actually just call out to people. Whatever you are, rescue team, this is Stony Brook, ambulance team, whatever you are, you want to yell that. And you want to say, if you can walk and people can come to you and they can respond to the sound of your voice, then those patients are ambulatory. You want to tag them and direct them immediately. And don't forget, in that group, there will be some that are in shock. And so they do need to be evaluated, the walking wounded, to make sure you don't miss them. And then if you're finished with the voice call and you're having to actually circulate in a field, you want to start where you stand and follow a systematic route. You start with the closest patient and move one to the next, to the next, to the next. Don't jump around. You're going to tag them, treat any of the immediate patients that you can do to get them safe to be transported. And then you want to document these resources. So every patient that you find in a particular setting, you want to let people know you found the patient. So a quick way of doing that is just carry a chart diagram and fill it out. So in this case, I made a map of something, of a troll village from some game, marked it A, B, C, D, and then you actually want to put in each sector how many patients of each type are there so that the emergency responders can go appropriately. And this is just types of transport for patients. It's just a diagram to show you that there's options for 1 or 2 people to carry people. I'm sorry, so I have a little bit more detail that I could go into related to, hygiene and sanitation and these types of things, but for the gist of who's going to be, the talk, that's all that I need to do, I think. And I'm gonna stop sharing my screen and pass it on to Dr. Fuller.
While they're transitioning, just thank you to everybody who's been sending in questions. I'm writing them down and categorizing them, and then we'll just go through all of them at the end. So, thank you. And Dr. Fuller.
Dr. Hughes, thanks for that fantastic overview of triage. I appreciate it. My name is Matt Fuller. I am an assistant professor of emergency medicine at the University of Utah and the director of global health here. I've had the good fortune of working with colleagues in Syria in conflict zones before, and I feel really privileged today to talk to our colleagues from across the world who are under really significant and dire circumstances right now. And so before we get into the topic of my talk today, I just really wanted to acknowledge the really difficult circumstances that they find themselves in, and also acknowledge that the stuff that both Dr. Hughes and I are covering today is different than any medical education you'll really ever receive or have received. We're talking about the worst day in your practice as a physician, where you're really having to decide who lives and dies. And I contrast that to the environment in which the vast majority of us were trained and where we find ourselves today, where we never have to make that choice. We're devoting all of our resources typically to the most severe of patients that present to our institutions. And that is distinctly different than what we're talking about today. We're talking about, and in particular, in my lecture here, we're talking about making the decision, a very dualistic decision about who will have a chance at life and who will have a chance at death. And so that is a really heavy topic, and I don't want to minimize that in the least. So I just, you all have my sincerest respect for trying to provide care under these really difficult circumstances. So with that in mind, I want to talk about a few objectives with the talk today. I'm just going to talk, as Dr. Hughes did, very quickly about the traumatic distribution of deaths. I want to compare and contrast, as I just mentioned, trauma care in civilian and in conflict zones. And then I think the meat of my talk is really going through some cases together. And when we get to the cases, I'll remind you, but if you could just simply type it in your answer in the chat box, I think that will really help improve the education that you get out of this discussion today. And I'll simply ask you whether to identify the patient has fatal or non-fatal injuries. So we're all familiar with the trimodal distribution of traumatic death. There are those who die immediately, there are those who die in the days to weeks after, and then there are those who die in the first few minutes to hours after their injury. And that is really the cohort with whom we're interested in discussing today. Those patients typically are affected by what we call the trauma triad of death. And again, not to beat a dead horse, but I think there's a vast spectrum of learners on today. There are some that are very familiar with this and some that may not be familiar with this. And this is really composed of three different pathophysiologic issues. That's coagulopathy, acidosis, and hypothermia. And those patients in that early death cohort are those that can be affected by this most severely, and with whom we have an opportunity to intervene. So as I said, there are those who die immediately from their injuries, and those patients typically die either within the first 5 minutes or at the time of injury. And this happens because of overwhelming trauma that's incompatible with life. These are patients who suffer major head injury, massive hemorrhage, transection of their torso, massive burns. There are also those who die in the days to weeks after their injury. And these are also the patients that we're not really interested in talking about today. And while they're important, they're not really the topic of conversation today. There are those who have ongoing and worsening coagulopathy, infection, multi-system organ failure, cerebral edema, et cetera, et cetera. The cohort of patients that we're really interested in discussing today are those that comprise this early death cohort. And those are the patients that die within the minutes to hours, or in that classic golden hour that really is trauma dogma. And most of the science that supports this golden hour theory comes from the US military's experience in the Vietnam conflict. Exploring that cohort of patients that died in that conflict, we really see the vast majority of these patients died from either chest or head trauma, with some to a lesser extent from abdominal and extremity trauma. And dissecting that a bit further, we see that those patients who died within that group, there was a small cohort that died from exsanguinating extremity trauma, some that died from tension pneumothorax, some from correctable hemorrhage within the torso, and to a smaller extent, those who died of airway obstruction. And these really are the patients that may have a preventable cause of death for whom that we want to identify this preventable cause of death. Those preventable causes are really continuing hemorrhage, and again, typically of an extremity. Those who may have an impaired airway or inadequate airway protection because of their mental status, or those with tension pneumothorax to a small extent. That cohort has really been confirmed in the recent experience in both Iraq and Afghanistan, again, from US military data. So before we dive into really identifying those injuries, what are the differences between civilian and conflict settings? We know they're very different for a number of reasons. First and foremost, as Dr. Hughes touched on, the resources are vastly different. The number and timing of casualty presentation to either your facility or you as the loan care provider is far different. And really the theater of practice is far different. And by that, I really mean security. So complex settings by their nature have extremely limited resources. We know that surgical capacity varies extensively. Do you have multiple ORs? Do you have just one surgeon? How long have they been working? Do you have transfusion and blood bank capacity? Do you have specialty care? If you need a neurosurgeon, are they available? Do you have critical care to care for these patients after you intervene? These are factors that you should take into account when you are making decisions on patients and whether or not they are salvageable. Again, not factors that typically weigh on us when we decide who to intervene on, and certainly not for the vast majority of us who are practicing outside of a complex setting. But for those of you who find yourselves under extreme duress right now, these are factors you must consider. Similarly, how will an influx of casualties and their numbers affect your healthcare system? Will you caring for a new casualty impact the care of patients for whom you've already begun care on? Do you have flexible capacity at your institution? Do you not? You need to consider these things when considering whether or not to intervene. And last but not least, security. What about need to evacuate patients and or healthcare personnel? What about the transportation of those patients? Are you part of a forward surgical team? Are you a single surgeon? Are you operating in a large tertiary care center, perhaps, where you have emergency physicians like me or an anesthesiology team and or critical care capacity? Again, it's going to vary for all of us, and you must consider these things when you are deciding whether or not to care for a patient. So how do we recognize fatal injury? This is really our task today. And again, this is a very unpleasant thing to discuss, but I think it's really important, and it's far different than anything any of us have ever been trained to do. Our task today is really to identify those patients who need a life-saving intervention and have a decent chance at a meaningful recovery. And unfortunately, we also need to identify those patients with such severe injury that they are unlikely to survive, or would have, if surviving, a very poor quality of survival. So how do we do this? Those patients who need a life-saving intervention and have a good chance of recovery tend to have injuries to either the airway, such as minor burns to the face, trauma to the head with a reasonable mental capacity. And for those of you who are familiar with a Glasgow Coma Scale, we typically say a GCS over 8, or even those who require intubation or tracheostomy, but really have minimal or isolated trauma to the face and or neck. There are also patients with injuries to the chest, such as tension pneumothorax or isolated hemothorax without ongoing hemorrhage, or patients who may have significant hemorrhage due to wounds to the peripheral vascular structures, maybe traumatic amputation, perhaps internal hemorrhage that's amenable to control and compression in the context of having blood products available. And that's a very important caveat. Those patients, likewise, with injuries so severe that they're unlikely to survive or would have a very poor quality of life if surviving, are those patients who often have penetrating head trauma or significantly decreased Glasgow Coma Scale, less than 8, we say. Patients with significant traumatic paralysis are those patients who likely are not salvageable. Patients with very significant burns, patients with over 50% of their body surface area with burns will not, under the best of circumstances at a large tertiary care center with burn surgery and burn ICU available, have a great quality of life. And so those patients in a complex setting are really unlikely to survive. And then patients with major hemorrhage without access to blood products are also patients who we need to identify as patients with poor likely outcomes. Now, again, after identifying these patients, it's really important to talk about comfort care for these patients. These aren't patients that you simply leave and don't provide any care to, but these are patients that beyond providing some narcotics or pain relief or anxiolysis are patients that we should not devote significant resources to salvaging. That's a really hard thing for the vast majority of physicians to do, especially for those of us with no experience doing so. So now that we've talked about that a little bit, I want to go through some case examples, and I don't have I'll pull up the chat function here. But I'd like to go through some cases, and I simply want you to type in the case or in the chat function whether or not you think the patient is or has a survivable injury or a fatal injury. And then I'm happy to answer any questions when we complete. So the first case is a 38-year-old male who seems to have a penetrating chest wound. He's awake, he's talking, he seems short of breath, and he has no ongoing hemorrhage coming out of the chest. There are his vital signs. Importantly, he's tachycardic, he's hypotensive, he's hypoxic, and he's breathing at a fast respiratory rate. He appears confused. You see his trachea deviating to the right. He has decreased breath sounds over the left hemithorax. Is this a survivable or a fatal wound? Can somebody answer? Okay, we've got a few great responses there. Thank you for your participation, everybody. So this is a tension pneumothorax due to penetrating chest trauma. And while the patient is in obvious shock, it is easily reversible with either a finger decompression or a needle chest decompression. It will not consume significant resources, and their physiology rapidly improves. So I would classify this as a survivable injury, a triage category 1, to reference Dr. Hughes's talk. This is somebody who, after a very simple procedure, will live, may even be able to walk out of the theater, and for somebody that I would intervene. And we can go through these at the end. Dr. Davis, if you think it would be better to answer questions at the end, unless you think it would be best to answer questions on these now, if anyone has any concerns. Does that seem reasonable?
Yeah, if anybody has any specific questions about the case, please, you can either send it directly to me and I'll interrupt him, or feel free to put it directly in the chat.
Great, thanks. So case 2, 24-year-old male with significant head trauma with obvious brain matter near the exit wound. This patient is unresponsive to a sternal rub. So you're rubbing the sternum and there's very little, if any, response. Their vital signs, again, tachycardic, extremely hypertensive, very slow respiratory rate with an oxygen saturation of 88%. This patient has an obvious penetrating wound to the temporal scalp. There is brain matter upon the exit wound. They are not moving any of their extremities to stimuli, like I mentioned. However, they have clear breath sounds bilaterally and a soft abdomen. I'm seeing some great answers here. Anybody else want to venture a guess? I like Dr. Maddox's response, yes. Yes, so this penetrating head injury with a GCS or a mental status that is essentially unresponsive, GCS less than 8, would be a category 4. The survival is extremely unlikely under any circumstance. Even at the University of Utah right now, these patients do not survive. These are patients who go on to maybe donate their organs under the best of circumstances at a center with all of the resources available to them. Under triage circumstance, under conflict setting, this patient has an unsurvivable wound, and comfort care should be provided for this patient. So excellent job, everybody. 25-year-old female with traumatic amputation of the right mid lower extremity with a significant hemorrhage. This patient's alert, but very tearful, in distress. They're tachycardic, hypotensive, satting well on room air and tachypnic. Their physical exam shows her awake, alert, she's crying, she's responsive, she can tell you where she is. She has a soft abdomen, there's no other trauma. She has traumatic amputation of the mid femur, and there's obvious muscle, bone, and arterial bleeding. Is this survivable or fatal? Getting a couple responses. Very good, very, very good. So this is despite what Dr. Hughes says about tourniquet application, I agree with her. However, in the appropriate context such as this, it should be used. Immediate tourniquet application will likely save this patient's life. Surgical control of the hemorrhage of the arterial bleed is important after evacuation. And if available, limited transfusion. And I won't go into the details, it's beyond the scope of this discussion today, but the International Committee of the Red Cross in their surgical war training draw a distinction between transfusion, both in a conflict zone where blood products are extremely scarce, and this patient may meet the criteria for transfusion of perhaps 1 unit or even receiving whole blood if available. She has no damage to critical areas of the chest, head, or the abdomen, and there's a high likelihood of survival in these patients. So in case 4, 30-year-old male extricated from a vehicle on fire. He has significant burns. His vital signs are as follows. His physical exam shows significant burns greater than 80%, including face, torso, abdomen, extremities. They appear full thickness. Is this a survivable injury or a fatal injury? Wait for a few more responses. Very good. Everyone's doing such a great job with this. So this is a patient with significant full thickness burns to greater than 50% of the body with a very low likelihood of survival. And if so, very poor outcome, especially in a resource challenged environment. Again, just to remind you of the category this patient falls into. And so a likely fatal outcome. So well done, everybody. Case 5. 32-year-old female with a blast injury to the face with significant jaw trauma. She's responding to the staff, although her airway seems compromised. She's making gurgling noises. Her vital signs show her to be tachycardic, slightly hypotensive, slightly hypoxic, slightly tachypnic. Show partial traumatic amputation of the mandible with what appears to be an obstructed airway and very difficult anatomic identification. She is following commands. You tell her to raise her hand, put her hand down, open her eyes, close her eyes, she'll follow. Is this a survivable or a fatal injury? Again, it seems slightly isolated to the mandible. We've got a couple of answers here. So this is a patient with significant airway obstruction, but otherwise minimal traumatic injuries. And this is a survivable injury. This is a patient on whom we can intervene and perhaps save their life with minimal consumption of resources. This patient, I would, if I were in my emergency department, get the most experienced person with managing airways. For many of you, you may not have that option. And so you can attempt to intubate orotracheally if you can find bubbles in the back of the throat, which we would consider a blind intubation, but perhaps a better approach would be a cricothyroidotomy if we can maintain that airway. And we can discuss that procedure later if you all are interested. Very good. So 17-year-old male with a large gaping abdominal wound. This patient is obtunded. This patient is moaning, not making much sense. Your facility has limited access to blood products. Again, you're in a conflict setting. The patient appears in obvious shock. Patient is not following commands, appears pale, mottled, has a large gaping wound in the right upper extremity with very significant and ongoing hemorrhage. Is this a survivable or a fatal injury? Yeah, a lot less disagreement over this. This patient very clearly has ongoing and significant abdominal hemorrhage, and without access to significant transfusion has poor likelihood of good outcome, even under the best of circumstances. Furthermore, they would consume significant amount of available blood and consume surgical resources, such as an operating room and or multiple surgeons. And so likely a fatal outcome for this poor patient. So very good. Last but not least, case 7. This is a 23-year-old female with significant facial burns from an explosion. She has what appears to be soot in her sputum. She has a hoarse voice. She appears very anxious. Her vital signs appear as follows. She has burns around her nose. She has soot on her tongue. When you auscultate bilaterally, you hear coarse breath sounds. She appears in respiratory distress, but her total body surface area of burns looks less than 10%, just the face. Is this a survivable or a fatal wound? I'm so happy everyone is participating. Thank you all for your participation. This is great. So this is a patient, again, who requires emergent airway protection, for whom they very soon, if not already, will be experiencing very severe airway edema. And so again, the most experienced airway provider should attempt an orotracheal intubation if possible, and if not, perform a cric or a cricothyroidotomy is what we often call it. And these patients typically recover very quickly after a period of 24 to 36 hours with minimal support. For those of you unfamiliar with the cricothyroidotomy procedure, it's simply identification of the cricothyroid membrane. You can palpate it just below your thyroid cartilage currently. And it's simply an incision with a scalpel and insertion of a cuffed endotracheal tube. This patient, again, fits in the category 1 of serious wounds of somebody who we can intervene on with minimal support, will likely survive. So very good. So just in quick summary, preventable deaths in conflict trauma are largely due to extremity hemorrhage, pulmonary pathology, or airway compromise, and identification of those patients is imperative. And then intervening to blunt the triad of coagulopathy, hypothermia, and acidosis is really what our aim is today. But equally important is recognition of patients with unsurvivable injuries so that we can preserve resources for those who may survive. Thank you for your attention today. And without further ado, I'll pass it over to, I think, Dr. Davis and Dr. Jayaraman. So unless there are specific questions.
Yeah, so I have a long list of questions, but before we launch into those, I think perhaps we can start with Dr. Jayaraman. Do you have any comments or suggestions based on those 2 lectures? And then we'll see if Dr. Maddox has any comments, and then I'll pitch all 4 of you some of these questions.
Thank you so much, Dr. Davis, Dr. Hughes, and Dr. Fuller. It's been a pleasure to listen to your talks. The comments that I have are a few related to the practice of triage in the field, which really depends on the situation. Whether you are being called to a scene of an explosion or whether you were at the scene of explosion already as a community member and therefore may not have access to any of your medical resources and have to perform triage without any other support. How you control that environment when you may have bystanders who are quite anxious, how you may control that environment in creating and leading a team are important questions that you need to think about ahead of time, as Dr. Hughes mentioned. The challenge of tagging the victims may be difficult. You need to create a system where you can do that so you can easily communicate to any other medical personnel who are arriving to the scene. For example, it may involve taking a pen and writing on the person's forehead what category they may be, or writing on their chest, certainly if that's acceptable, and probably male patients, what their status is, so that teams that are arriving can support support you, especially if you're on the scene and don't have any of your medical resources at hand. So those are some additional thoughts that I think practically we need to be thinking about in responding to major conflict settings. So with that, I'll turn it over to Dr. Maddox.
Thank you for the opportunity. I certainly agree that using a Sharpie and writing on the forehead, on the chest, on the abdomen, dating it and timing it, since these patients will be moving through several echelons of care. I want to share with you one trick that I found very useful, both outside the emergency room and in the field when you are overwhelmed with more patients than you can take care of. And that is tell everyone to sit down on the ground, setting up. Sit down on the ground, setting up, regardless of the etiology: car wreck, explosion, nuclear, gunshot wounds, trampled, such as at a rock concert. Those individuals who are in shock will fall to the ground by leaning over because that's the natural physiologic response. Those individuals who have an adequate cardiac output will remain sitting. So you can free up your hands and brain by assigning someone and say, anyone who falls down, take them to the sub-triage area. This will be less than 10% of the total load, regardless of the cause of the mass casualty. So you don't need any fancy equipment. You don't need a pulse oximeter. But if you have a pulse oximeter to test the oxygen saturation at the finger, that's helpful. But having a Sharpie pen, setting people on the ground, you will quadruple your ability to evaluate mass casualties. Thank you for the opportunity.
All right, I'm gonna share my my document just so you can all see it. And then while I'm doing that, I actually have a couple very quick questions that I put at the top. And let's see. So these are intended to be sort of rapid fire because we only have 8 minutes. So the first couple, let's give just very quick answers to. So regarding tourniquets, how long can they stay without necrosis? And if you find that it's loose during transportation, should you apply another one over the old tourniquet or remove it and apply it again?
I think that typically a tourniquet, most limbs will have irreversible changes and gangrene type of events if you leave it on longer than 6 hours. I mean, that would be the goal, to get intervention before that time. And in terms of the logistics for the tourniquet during transport, in some cases, I have heard both, where people have actually applied the secondary tourniquet a little bit higher than the one that was on, as opposed to taking off the old one. So you don't necessarily want to take off the tourniquet unless it's completely off and you don't have, there's nothing happening. Then of course use the same one. But typically you want to put one closer to the heart if you can, above the level of the previous tourniquet.
Okay, finger thoracostomy. If the patient is awake and stable, should you go ahead and do it while intubating, or do procedural sedation and analgesia first?
I think it depends on whether or not the patient is dying. If the patient is dying in front of you, of course you want to provide comfort, but their survival comes first. And so in that case, you do it immediately. And if you have a large angiocatheter, it's really not that painful. I mean, it's akin to putting in an IV if you do it in the third intercostal mid-clavicular line to decompress a patient. It shouldn't be an issue. If you only have a scalpel and a finger, just do it if the patient is dying. So I would say it depends, like a lot of these.
That's right. You can do it awake. It hurts, but it will save their life.
All right. If you have a patient who is in shock, who has underlying COPD and heart failure, is there a preferred position for the patient?
Actually, I actually don't think that I would be able to tease out whether or not the patient, do you get what I'm saying? I would use the same shock position for all patients because, you know, by the time you start asking about their past medical history, you spend too long triaging that patient kind of thing. Okay.
All right, great. And
I agree with Dr. Hughes.
yeah, I think the meat of what people mainly had questions of was regarding triage, and I got a lot of the same questions. So one very common question was, who is serving as a triage officer? Do you need a specific dedicated team for triage? Should it be doctors or should it be paramedics? And is it permissible to do triage by telephone or some other mechanism like telemetry?
So a lot of the rest of the talk was just a tiny bit about setting up the team and making a plan. And this is where it comes into practice. So a lot of times, not only is the triage team not medical professionals in some cases, but also there are people that also have been in the incident and are walking and capable of assisting. They will add to the team that's helping you to triage. So in that case, it doesn't have to be a medical professional, but the person that's charging and leading in terms of pushing should be someone with, EMT or physician background, as long as they have experience in triage and plan. Because it's not just triage on the field, it's also where are they going, where's sanitation, do we have supplies, all of these other things that come into play that need to be planned by someone that has an understanding of what's necessary to set up a triage and treatment field.
I'll just emphasize what Dr. Hughes is saying, that if you use somebody who's inexperienced or worse, it will become an even greater mess with more casualties. And so using somebody who can navigate the triage space because they have either experience or less anxiety is really integral to making certain that this is a successful effort. So, and that's true in the emergency department or out in the field. So.
And in terms of how many surgeons or emergency physicians, you don't need any, as long as people know the criteria that they're looking for. And as you know, we discussed today, anyone that has the basic criteria can evaluate the patients, can do it.
All right. One question I also got several times was the quantity of physicians needed for triage. And that might be a challenging one for you to answer, but people were asking for one mass casualty incident or one battle, how many physicians are needed for that?
I mean, that's what I'm talking about. You don't need any. As I presented, it actually is a community response field triage talk. So this is for community members to do. No one that has any medical training except the basis to respond to stuff. Now to treat, that's, to transport and treat, that's step 2 and 3, and that's different. Then you're going to need a certain number of practitioners, to manage so many patients. And like we talked about, if people have severe injuries and they tie up a lot of time, then that's going to take away from other people who have immediate things that need to be addressed, but can be addressed quickly.
This is Maddox. The Israelis have a novel way at triage outside the emergency department. They have an administrator being triage officer, and anyone that is a walking wounded and talking, they do not let into the emergency room. Only those people who are on stretchers or who look like they really need attention. So they really are they're a bouncer to prevent all the excess traffic of gawkers and people with minor walking wounded injuries into that area of critical care.
I think the real challenge too is the type of situation, whether you're at the emergency department or whether you're in the middle of a market where there's an explosion, and you have to then create a team of the people around you to help conduct the basics of triage. I don't know if anyone has any experience with that who can comment.
I think you're absolutely correct. Before I go off, there has been a lot of talk in the recent weeks about the use of nuclear weapons, limited nuclear weapons. Most of us have forgotten everything we learned about nuclear. And I think with the static which is going on around the world right now, it might be well to review nuclear either here or at your own institution in order to protect yourself from the alpha, beta, and gamma waves, and how you determine that, and how you treat the patients, especially those who might have had a huge dose of gamma. We've forgotten it. Refresh your memory just in case there's an explosion in some nuclear power plant.
All right. Someone actually just asked a question related to that. Is there, where is a safe location to triage in the case of some sort of nuclear war?
I mean, the most important part for triage in that setting is actually, I talk a little bit also in my slides, which are in PDF form if people want it, that, you know, you want to have your field out of a flood zone. You want to have the field up, you know, upwind of fires, or, you know, these types of things. And so with radiation, you want to be outside of the zone, but people have to go in and put on gear to actually triage and get the patients. It's just where you're sending them is going to be the difference.
All right, and we should be done now. So just very, very, very quickly, how do you avoid over triage and under triage? And if you're in a situation where there are very severe cases who are dying, how do you go about giving up some severe cases to save others?
I didn't talk about this very much, and Matt touched on it as well. In most, you know, medical systems, we tend to over triage patients. So a single patient comes in, they're an extremist, they're making a lot of noise. Okay, we put all of the resources we have into treating that one patient. And that is the basis for our medical practice these days. And so in the triage setting, you can't do that. You have to make harsh decisions, and it's actually difficult and challenging to do that. And then under triage, and this relates to the walking wounded, you do still have to assess patients to make sure that they're, you know, not breathing above 30 breaths per minute. You want to make sure that the cap refill on that person is good. Exactly, Dr. Maddox, it was such an amazing thought to have the patients all sit up. So this person may stagger up, or, you know, walk sideways or fall down. And this is someone that you need to look at more carefully.
All right, and then I think this one is similar to what Dr. Jayaraman had mentioned. How does it differ if you're in the ER versus in a battlefield or another setting?
Oh, it's completely different. So this is actually we could actually absolutely have a talk about triage in the ER with Dr. and then separately about inpatient and ICU triage. These are all separate.
Okay, great. And I think that that's really all the time we have. Thank you so much to everyone who submitted questions and who has participated. Our next, we'll be putting up the date of the next event, but I believe that it's the 28th. Let me just double check quickly. Yes, it's the 28th at 8 a.m. Central Daylight Time, or 1 p.m. GMT. And so we're really looking forward to seeing everyone then. Thanks again, and please everyone be safe. And I'll put my email in the chat if anybody has any questions or feedback. You can just email me directly. So thank you all.
Thank you. Stay well, stay safe.
Thanks so much. Good luck.